Okay, I think we're going to start with introductions. So like I mentioned, I'm Maria Espinola. I am a psychologist and faculty member in the Department of Psychiatry at the University of Cincinnati. I'm also a co-founder of the UC Latino Faculty Association, and I am super excited today to introduce our keynote speaker. She's Dr. Margarita Alegria. She's one of the top researchers in the world in the area of health disparities. She is the chief of the Disparities Research Unit at Massachusetts General Hospital and the Mongan Institute, the Harry Lehnert Jr. and the Lucille Cyr Endowed Chair at the Mass General Research Institute, and a professor in the departments of medicine and psychiatry at Harvard Medical School. So you all have received her bio, so I'm not going to spend a lot of time on that because, and you know, like whatever time I spend is not going to be enough to really share all her accomplishments and all the contributions she has made to the field. So let me welcome now Dr. Margarita Alegria and let her start her presentation. Good morning, Dr. Alegria.
I'm delighted to be really speaking today, especially because a lot of the work that I'm going to be talking about is work that really touches upon disparities. All the work we do as part of a team is really disparities focused. Let me start with my slides. Jenny is going to be so kind enough to start with the slides. And I'm really looking forward to making this a very active, interaction, because all the work really is for you. It's for people in the trenches that are really doing the work of disparities. I want to start by saying that I have let me just say my team is really the one that should get the merit of all the work we do. We are a team of 23 people in the office, including Jenny and Duan that will be speaking to you today. We have an incredible, talented, inspired group of people that make our team at the Disparities Research Unit. So let me start by saying I have no conflicts of interest. Next, Jenny, if you could pass. I wish I had, but nothing. When you do disparities work, you really don't go in terms of having a lot of money or resources. So let me go there. I want to simplify what I'm going to cover today in three main messages. And these messages are important because if I walk you through a whirlwind of studies and really recommendations, these are the three main things that I want you to take away. One, that service disparities in treatment of both multicultural population, people of color, is something that needs serious attention. I think COVID really magnify the importance of taking this very seriously, and that we have to move it up in our radar screen to the top of the list. I think the second thing I want to discuss today is that there are no easy solutions to disparities. I'm going to walk you through why they have been persistent, why they're what we call a wicked problem that doesn't seem to have actual solution, and that for the last 55 years, we still talk about disparities and the needle is not changing. So really, to be able to make the needle change, we need to have multi-level interventions that engage, retain, and effectively treat people of color. So I'm going to talk a lot about that. And the third message is that to have traction in service disparities, we really have to change the policy, the system, and the way we currently offer care. What we're doing is not working. We know it. We have enough information to know what we need to change, but we really, really need to have the will to change it. And the role of clinicians, researchers, and policymakers is central. That's why you're such an important aspect and asset to make this change. We need a social movement, and I'm going to talk about that social movement to really move the needle. Next. The agenda for today is I'm going to move you all very quickly through talking about mental health disparities, showing you some data if you're by any means not convinced. I'm going to then walk you through frameworks of why disparities persist and persist and persist. Then I'm going to talk to you about interventions And I'm going to talk about interventions that we have been able to conduct at all levels, at the policy level, at the community level, and at the clinical encounter level, to show you that there's a way to change these disparities, that we can really move the needle. And finally, I'm going to finalize with getting your recommendations and exchanges in terms of how can we make it work? How can we make it work across systems of care, across different contexts, and with people of color in different areas? Next. So let me tell you just how badly we have gone wrong. How badly is this issue of disparities both in minority and immigrant groups? Let me show you some data to move it forward. Next, I want to start with data that will show you that we have a history of blaming the victim. We call them the group that's hard to reach. We call them non-adherent populations, vulnerable, non-compliant. But if you think about it, and the data I'm going to show you, I want you to take this message. We are blaming the victim, and it's the system that has failed them. The system we have in place does not work, and that's why we do not move the needle. So next, let me show you some data, and this data is quite recent. It's 2018 Agency for Healthcare Quality report, and this is a report that does national benchmarking of how are we doing. It's a national study, and it basically is done by an agency every year or every 2 years. And since 2000 to 2018, what we find is that the disparities are getting a little bit smaller, but not, this is really for the poor and uninsured populations, the disparities have remained the same. In patient safety, in person-centered care, in effective treatment, in care affordability, we have not changed. Let me show you some data to just show you visually what this means. These are access disparities measure, and what they do is they compare data from previous years to see, is it changing? Is it becoming better? Is it becoming the same, or is it becoming worse? I want you to see the first bar, which represents poor versus high income population in 20 indicators of access. And in 19 of those, we're doing worse. And in 1, we're doing the same. I want to show you Hispanics, which is the last column. And in that, you can see for 15 indicators, we're doing worse. For 2, we're doing the same. And only for 3 are we doing better. If you look at Blacks, the story is quite similar. We're doing, for 9, we're doing worse. For 11, we're doing the same. And only for 1 are we doing better. So you can see here, it's really not really getting better. That green is almost non-existent in the indicators. Let me take you to the next one. This one is quality. And you can see here again that it's not changing. The blue means not changing, the green means improving, and the red means worsening. And in terms of quality indicators, for 56 quality indicators in 52 for Blacks, it's not changing. And this is looking across the board since 2000 to now. This is data 2018. The same you can see for Asians, we can see for Hispanics, 42 out of the indicators of 49 that we have for Hispanics, and only in 2 and only in 5 are we seeing some improvements. Let me take you now to the next one to show you even something as basic as major depressive episode. If you look at the changes over time, you can see here again the actual rate of whites receiving treatment, who are the light blue at the top, is fairly high. But when you go to, for example, non-Hispanic Blacks and Hispanics, with are the orange and light orange, you can see the rates are still very, very low compared to the top white group. And this is major depressive episode for which we have guideline concordant care, for which people have been trained, and we still do poorly. Next. I think one of the biggest ones that I'm very concerned about is suicide risk among Black youth. This is one that we're seeing that is skyrocketing. It's the third leading cause of death among Black males ages 15 to 24. It's 1.2 higher rates of attempted suicides by Black males compared to white males. And it's 2 times higher rates of suicide in Black youth ages 5 to 12 than white youth of the same. So you can see of the same age. So you can see here that we still have disparities and the needle is not moving. Next. I'm going to show you now treatment completion rates for alcohol and major drug categories. And you can see the blue is the white, the red is the Black, the green is the Hispanic, the orange is the Native Americans, and the purple is the Asian Americans. And this is completion of treatment. This is work done by Salinger and Cook, one of my colleagues. And what you can see there is actually Asians are the best in completing treatment once they get in. It's interesting that they are not the ones that get in very typically. So there's an access issue that I can talk later, but the ones that actually make it through the boundary of getting into treatment are more likely to finish. However, for all the other groups, Black, Hispanics, and Native Americans, they are lower completion rates for most of the drugs, and we're gonna talk about it. Next. What are the issues that people have identified as being central? One, obviously, the low provider diversity, but also diversity in leadership. If you look at how many healthcare systems have leaders that are people of color, it's extremely, extremely low. The rates go, depending on where you go, between 2 and 4% of the leaders are either Black, Latino, or people of color. There's also very few culturally and linguistic competent providers and institutions. We don't have that many. And there's service silos that really don't understand all that people have to go through to really make it work. There's unequal community resources. This is one that came up in COVID. How few community resources are at the local level that people can get the information, the connections, and then the referral to get into care. And then there's huge geographical differences between urban and rural, frontier and borders. Like yesterday, I was actually in a conference, and people were talking about how difficult it was to get care if you live in a rural area and you're trying to connect to services. Next. I also want to touch upon COVID-19 because I think, like people are saying, racism is the pandemic that we have to avoid. For example, the rates of disparities in hospitalization and death, even when we adjust for everything, show that this is not really an issue of race. This is an issue of social injustice that has perpetuated that people are going to have more chronic conditions, worse outcomes, and that the access to quick, for example, for people to get testing, it was terrible in our minority communities. Even though we knew that they had higher rates, they had very similar rates of testing as people in very low COVID communities. Next. So I want to today cover a few things where I think this is really worth discussing, because people ask, how come we have, since the 1950s, people have identified that there are some disparities. Then in the 1976, there's been a lot of reports about, we have to attend to these disparities. And then we had, several reports, including the Surgeon General's report on ethnicity and race. We've had the equity chasm report. So along the way, we have all of these reports, but it doesn't get fixed. It does not get fixed. So I want to cover with you 4 reasons why I think it doesn't get fixed. And let me go to the first. Nancy Krieger did a really, really nice theoretical framework showing, this is not going to get fixed. This is really an issue of oppression. And this is what they call the eco-social theory of disease distribution. And it's pretty much that we in our society are the embodiment of what we receive. And what she said, which I think is a really fabulous way of summarizing, is that there's what it's called the eco-social inverse hazards law. And it means that those that have the fewest resources are going to accumulate more hazards. And those hazards have to do with discrimination, deprivation, harmful exposures to toxic waste. And so as a result, what you're going to have is this social inverse hazards law. And what we have to look at is who are those people and then move resources to them. Let me tell you the second theory that I really like that made a compelling argument of why. And this is a theory proposed by Phelan and Link. And what Phelan and Link said, which I think is, it's, how should I say, it's both tragic, but it's sort of true. They said racism is a fundamental cause of inequities in health, and it's not going to change unless, one, we disrupt power, because it's really a fundamental cause that cannot be eradicated because there are enduring inequalities in knowledge, in money, in power, in prestige, that make sure that once you actually take one mechanism out, it gets substituted by another one. And for example, this is a good example of cardiovascular disease. Cardiovascular disease, we've made huge strides in cardiovascular disease, but who have gotten the benefits of statins and the medication? And it has been mostly the white population. So when you look at who is benefiting, even though we get, increases in knowledge, increases in new medications, it's really a very different group. And what he said is, there's so much stress, social stress, that is going to have a physiological response in poor people, that you're always going to be substituting, this racist mechanisms, one over the other, over the other, over the other. Let me move you to a third one, which was really given by David Williams. And David Williams talked about 3 major causes that maintain what we see today. One is institutional racism. And that's basically we take away resources or don't give access to resources for the non-dominant subgroup. So for example, this can be in education or this can be in social mobility. A good example of this has been with immigrant populations, how even if you have a higher education, it doesn't lead you to the same social mobility that if you are having the education and you're native born. So how immigrants, even with the same education, don't get the benefit out of that education. So it's showing you institutional racism to get to the resources, and even when we get there, how they don't pay the same way. There's also cultural racism, which means more the effects of economic status and health through stereotypes. And that could be, I think people think about stereotypes as only our impression of, race and ethnicity, but it could be accent, it could be power differentials that make some groups be valued over others. And this is a really phenomenon that I really want to talk to you about. And then racial discrimination, which is the physiological stressors that people that have chronic daily discrimination feel, but it's also in very subtle things that people have. Let me give you the example of, for example, racial discrimination in who can work at a distance versus not. We know that the difference is immense in, for example, populations of color being able to work at a distance. A very good example of this is also the difference in having a fixed routine of work. The most like the workers, the blue collar workers that have the worst routines, even within the same organization. There's a sociologist that has done this work together with economists, showing that, for example, even in a place like Walmart or Target, the people that have the worst unstable routines of work are people of color compared to whites in that same organism. So just to show you how it works from one to the other. Let me show you David Williams' example, because I think it's a really good example to show you his model. Next. And what I like about this model, this framework, it really looks at the basic causes of disparities. And he looks at things that have to do with geography, societal institutions, and racism. But look at the proximal pathways. He talks about the cultural transmission of how we replicate this social injustices, the stress, the socioeconomic opportunities that we give people, and the societal resources that we share, or the knowledge. And then he talks about how this ends up in terms of our responses, and then how it affects morbidity, mortality, disability, and mental health and positive health. Let me move to the next one. And this is the last, one of the last ones that I'm going to talk. But this is one that people have not really understood very well. And it's how important are cultural processes that really reinforce what we see at the macro level. And this is Michelle Lamont. She's at Harvard. She's a very, very wonderful sociologist. And Michelle Lamont talks about how individual level cognitive processes influence both the macro level processes, but also really work in the production and reproduction of inequality. And this is important because we have to keep these inequalities in operation. And she says that it's cultural processes that we use. And these cultural processes have to do with symbolic domination. For example, if you remember language, when they force people to only accept English as the dominant language and not allow people to use their language to reproduce these schemas, these social schemas. Or, for example, how we apply social categories to make sure that people perceive and evaluate different groups in a different fashion. Let me show you the next slide, because I'm going to use the example of COVID to show you how she thinks this happens. And there are two mechanisms that she says are really important to fit into the inequality. One is identification. And this is how we tend to very, very quickly identify people as having value, less value, or more value, and how we ourselves introject that evaluation. This is what I call the social mirror, how we actually take in that information. And that could be by racialization, which is that biological markers where we see someone as a clinician coming in the door, and we make attributions of that person based on how they look, how they talk. We have great evidence that even when people call on the phone, there's a great study that was done showing that how that person sounds. And they had actors doing the sound of someone as a blue-collar male worker, a black blue-collar male worker, a white blue-collar male worker, a female white collar worker, and they show that people, blue collar male that was a Black worker, blue collar worker, never got responses back. People didn't return the call for asking for an appointment compared to the other groups. So there's a racialization that is very immediate. And then obviously the stigmatization of how we judge people based on very subtle stratification. For example, I tell people that in Massachusetts, we do a lot of this stigmatization based on where did you study. So if you went to an Ivy League, you have a different value than if you went to a different school. And so people make choices very quickly based on how you studied and where you live. The same is rationalization, and this is how we rationalize why certain people have certain values or not. And I think this is important because what we find is for COVID, we rationalize how we were not going to give ventilators to people that had chronic conditions. But guess what? That was a race decision because the people that had more chronic conditions ended up being the Blacks and Hispanic people. So that was a rationalization of why ventilators were going to be given to different groups. So let me go to the next one. And I'm going to finalize with complex system approaches. And what I like about Diaz Ruth, she's the dean actually at the School of Public Health in Drexel. But Diaz Ruth talks that disparities also persist because we are really not addressing the main causes. We are addressing mostly at the patient level what's happening at that patient, but we're not really looking at the system thinking to try to identify what are the reasons behind that are making the causes for these disparities. And that's what we should be doing. So let me take a question. I'm going to stop here for a second to get some questions, and then I'm going to move to now interventions.
Yes, so we do have a question coming from Naga Pokala. And Naga, I am going to unmute you now. Okay. Good morning.
Good morning.
Good morning.
I just had a quick question about when you were discussing the theory, one of the theories of why disparities exist, and you were talking about how, like, even if intervention is attempted to solve one of the mechanisms, it still get replaced. So I was wondering if you could kind of discuss how that occurs, I guess.
Yeah, it's one of the things people have talked about is the replacement of these mechanisms by, for example, withholding information. You could withhold information and really target certain groups for treatment so that you actually, let's say there's a new treatment. This would be an example where you actually don't give information to certain groups, let's say the people in power, and really focus your attention on academic, for example, healthcare systems that are visited by mainly people that have money, have resources, and therefore you actually give the benefits of the newer interventions. This is an example of I work with a lot of my mentees. One of my mentees was doing a great study on statins and finding that actually the older statins were the ones that were giving to the Black Americans compared to the newer that had less side effects to white patients. So that's an example. So the idea that Phelan and Ling had is that we have to have disruption of power. We have to really work on trying to convince the people at the higher levels of power that it's really not in their best interest to refrain from including the benefits of the benefits of, like, for example, healthcare to all the groups. A good example of this is COVID. People are now saying, well, we need to do a better distribution of the vaccine because, we can't keep on thinking that if we don't give the vaccine to people of color, we are just not going to make it. The immunity that we're looking is just not going to happen. So disruption of power is what we're looking into. How can we change the policies? how can we change the resource allocation so that it doesn't get repeated from one thing to the other, because we're not moving, for example, a lot of the evidence-based treatments that they're in mental health, if you look about it, they're only being kept in certain institutions, but not being implemented in low resource environments. So thanks for that question.
Thank you.
Excellent. Let's see if we can get more questions.
Jenny?
No, something that I was thinking about, because you were talking about the vaccine, and something that I've been thinking about a lot, and I really wanted to get your input, is that now that the vaccine trials are rolling out, I have seen that the researchers are trying to recruit from historically Black university and colleges to get Black people enrolled in these studies, especially because, and I feel I wanted to give you an impression, because my initial reaction was that I'm conflicted, because historically science has really harmed communities of color, but at the same time, I think it's very important, as a Latina myself, I think it's very important to recruit Latinos, because a lot of Latinos are also dying disproportionately compared to whites. So I just wanted to get your
Yeah, I think we're all in that same boat, Jenny, because of what we have seen. But I think one of the things that has been changing dramatically, and it has been because of people disrupting power, is actually creating groups at the community level that represent the best interests and transparency for all of these trials. So for example, I heard yesterday in NPR that they're actually trying to not only recruit from these groups, but actually bring the community to be at the table in the decision making of when and how and what vaccines are going to be delivered. And I think that having people at the table that represent the interests of our communities of color is going to make the difference. I think before it was more like using the communities rather than sharing the decision making with our communities. And I think that that's where we need to disrupt power.
Read
I
it.
can read it. It's from Michael Odio. You mentioned that you are approaching this as a wicked problem. I agree that this is a wicked problem. Can you share insight on how that framework has worked in identifying paths to progress? Thank you.
Yeah, I think that's why I said, Michael, thank you for that question. I'm moving it as we need to do a social movement. I'm actually got a revise and resubmit for a paper where we are actually proposing what needs to happen for the next administration in behavioral health. And one of the things we're talking about is how do you break up resistance? What are the, think of it, instead of thinking about, I'm going to do an intervention, I'm going to do a program, I'm going to talk to policymakers, trying to see now this change in the areas that we want to do in behavioral health as a social movement. And looking at the literature, what I have done is looking at the literature of how have social movements that have been successful worked? What are the actual things that they have in common? And I can tell you a few of the things that they have in common is they build coalitions. So one of the things I'm proposing in this paper that hopefully gets published is the importance of building coalitions of people that share the same importance of behavioral health and moving monies that were allocated to other areas of the system, like, warfare or, others, to make sure that they are included in for mental health, either at the community level or at the intervention level. And so the other thing we're doing is looking at, for example, besides building coalitions, how can we create social awareness of the importance? People are more likely to know about their dental program than what their insurance covers for mental health. It's tragic that when you ask people, what does your insurance cover for mental health? People don't know. They haven't really looked at the program to see, does it cover enough? Am I going to have a good provider network? So we need to create more social awareness that the rates that people are going, the likelihood that people at some point in their life are going to have a mental health or substance abuse problem is actually quite high. It's in the 50s. If you look at the work of Costello, looking at a whole cohort of people over time. So that's what I'm hoping we can do.
Thank you. And Michael, for a second, Michael, if you have any other thoughts, comments?
No, that's very helpful. And, even I'm working on a separate type of wicked problem, which is why that really stuck out to me. But that really illuminates a lot. I really look forward to that paper.
Okay.
Thank you. And Michael, by the way, he's also a co-founder of the UC Latino Faculty Association. He's a professor in the sports administration department. But what we have found, over the years about meeting faculty members across the university is that we all care about the same issues, but we are looking at it from different lenses. So it's interesting to work together and collaborate.
Sounds great.